Osteomyelitis. Osteomyelitis is inflammation and destruction of bone caused by bacteria, mycobacteria, or fungi. Etiology and risk factors. Continuous spread from infected tissue or an infected prosthetic joint. Bloodborne organisms. Hematogenous osteomyelitis. Open wounds from contaminated open fractures or bone surgery. Trauma, ischemia, and foreign bodies predisposed to osteomyelitis. Contiguous spread from adjacent infected tissue or open wounds causes about 80% of osteomyelitis. It is often polymicrobial. Staphylococcus aureus is present in is greater than or equal to 50% of patients. Other common bacteria include streptococci, gram-negative enteric organisms, and anaerobic bacteria. Osteomyelitis that results from contiguous spread is common in the fetal patients with diabetes or peripheral vascular disease, at sites where bone was penetrated during trauma or surgery, at sites damaged by radiation therapy, and in bones contiguous to pressure ulcers, such as the hips and sacrum. A sinus, gum, or tooth infection may spread to the skull. Pathophysiology. Osteomyelitis tends to occlude local blood vessels, which causes bone necrosis and local spread of infection. Infection may expand through the bone cortex and spread under the periosteum, with formation of subcutaneous abscesses that may drain spontaneously through the skin. In vertebral osteomyelitis, perivertebral or epidural abscess can develop. If treatment of acute osteomyelitis is only partially successful, low-grade chronic osteomyelitis develops. Signs and symptoms. Patients with acute osteomyelitis of peripheral bones usually experience weight loss, fatigue, fever, and localized warmth, swelling, erythema, and tenderness. Vertebral osteomyelitis causes localized back pain and tenderness with perivertebral muscle spasm that is unresponsive to conservative treatment. More advanced disease may cause compression of the spinal cord or nerve roots, with radicular pain and extremity weakness or numbness. Patients are often febrile. Chronic osteomyelitis causes intermittent months to many years bone pain, tenderness, and draining sinuses. Investigations. Erythrocyte sedimentation rate or creatine protein. X-rays, MRI, or radioisotopic bone scanning. Culture of bone, abscess, or both. Management. 1. Antibiotics. Antibiotics effective against both gram-positive and gram-negative organisms are given after cultures have been done and until culture results and sensitivities are available. 2. Surgery. If any constitutional findings e.g. fever, malaise, weight loss persist or if large areas of bone are destroyed, necrotic tissue